Hi, I'm Dr. Harry Balian, and I'm going to talk to you about the broken heart syndrome. I think this is very pertinent and relevant to Heart Month, and February is Heart Month. I'm the chair of cardiology at Adventist Health Glendale, and I basically do structural heart, where I replace aortic valves, repair mitral valves, and do also Watchman procedure. Also, I do complex coronary interventions, peripheral interventions, carotid stenting, endovascular stenting, etc. I've been in practice for many years. I've been a board member of the Armenian Medical Society since 2006. So today we're going to talk about the broken heart syndrome, and I'm going to define the anatomy of the heart, discuss vignettes on a patient that I took care of, and outline stress hormones that affect the heart function, describe broken heart syndrome, treatments and cures. We'll do a couple of quiz questions and final remarks. No financial disclosures. So 69-year-old patient that I recently took care of, she's a retired JPL engineer, lost her husband 4 months ago to a massive heart attack, developed crushing midterm chest pain at home, and was basically brought in by paramedics to Adventist Health ER. Upon arrival, she was hypotensive, bradycardic, and also tachypnic. So on exam, she had bilateral rals, and heart rate was slow. She was very lethargic because she was hypotensive, and she was having crushing chest pain. She was rushed to the cath lab, and upon arrival to the cath lab, unfortunately, she rested on the table. We did CPR, promptly got a pulse back, and basically started performing the cardiac catheterization. Initial EKG is consistent with ST elevation MI anteriorly, when we were almost sure that she had closed her main artery, and that was probably the culprit of her developing hypotension and also cardiac arrest on the table. The rhythm is as follows. Initially, she was bradycardic, then she went to VFib arrest, was shocked promptly, and regained a pulse. So her coronary arteries, much to our surprise, were pristine. Her left main, left anterior descending artery, the circumflex were open. The right coronary artery also was patent. Again, this was sort of a puzzle because she had widely patent coronary arteries, yet she had chest pain, abnormal EKG, and a cardiac arrest. So what was going on here? So she further deteriorated, unfortunately, on the table. She had more hypotension, to a point where we had to start on pressors, and that was not enough. And promptly we initiated the Impella cardiac support device, where we accessed the groin and went inside the heart and put this pump where it pumps the blood from the left ventricle to the aorta up to 4 liters per minute. The bedside echocardiogram done showed severely depressed ejection fraction. Her heart function was basically very depressed, and that was the reason why she was in cardiogenic shock and heart failure. And looking at this echocardiogram, you see the heart at the apex of it is barely moving, and that's consistent with her MI and also cardiogenic shock. So again, what was going on here? We were again puzzled. The chest X-ray showed bilateral rals, bilateral pleural effusions, consistent with fluid overload and congestive heart failure. So the percutaneous device that we placed was the Impella, and that actually is a device that we go through the groin inside the heart, and we put this device that pumps the blood from the left ventricle to the aorta. Other devices in order to escalate this cardiac support would be ECMO, which is something that I'm going to talk about. So this is the Impella device. This is a device that goes and sits inside the left ventricle. It pumps the blood out of the left ventricle and into the aorta, and up to 4 liters per minute. And in this situation, patient on the Impella plus pressors was still barely struggling to maintain an adequate blood pressure. So what's going on with this patient? So she basically had broken heart syndrome. This is a patient that after intense sort of an emotional episode in their life, whether it's it's loss of a spouse or divorce or something very emotional, sometimes happy emotional outbursts can trigger this. So it's more commonly seen in women than men. It's often caused by emotionally stressful event, as I mentioned, and similar symptoms to a heart attack, and can lead to heart failure. So looking at the heart, it's basically heart is a pump. Its sole purpose is to collect blood from the brain and the lower extremities, the deoxygenated blood, and pump it to the lungs. And then basically after the oxygen is picked up in the lungs, comes to the heart, the right side, the left side collects the blood and then pumps it to the body. So basically the left side of the heart is the muscular side that pumps to the body. The right side, the right ventricle, right atrium, right ventricle, its sole purpose is to pump the blood to the lungs to pick up oxygen. The heart itself, obviously, has the coronary arteries. We have the left anterior descending, which separates the left ventricle from the right ventricle. The circumflex artery, which separates the left atrium from the left ventricle, and the right coronary artery, which separates the right atrium from the right ventricle. The LAD, left anterior descending, supplies blood flow to the ventricle and muscular portion of the heart. Circumflex artery supplies blood flow to the mitral valvular annulus, and then the right coronary artery supplies blood flow to the right ventricle. So all of these arteries are actually very important, and they serve their special purpose. So what is Takotsubo or broken heart syndrome? Takotsubo cardiomyopathy or broken heart syndrome is a weakening of a chamber, the left ventricle in particular, following a surge of stress hormones resulting from a severe emotional or physical stressor, such as death of a loved one, divorce, natural disaster, etc. And basically the heart balloons in the shape of this octopus cup. And I'll show you a picture of that. And as the heart is pumping, the entire apex is barely, it's not moving, it's actually bulging outwards. And this is the reason why patients are hypotensive. And the heart looks flat-bottomed, pot-like shape, similar to a Takotsubo or Japanese octopus trap. Patients can develop similar symptoms as a heart attack, namely jaw pain, cold sweats, shortness of breath, pressure in the chest, nausea, vomiting, all of the above. And we know that in women in particular, heart attack symptoms are actually not typical as men. They may have weakness, they may have dyspepsia, heartburn, not the classic Levine sign as patients may have when they're clenching their left mid or lower chest when they're having a heart attack. So anatomy of a heartbreak, according to researchers from Johns Hopkins who studied a condition called stress cardiomyopathy, sudden but reversible heart failure, highly similar to classic heart attack, is known as a Takotsubo cardiomyopathy. And basically it's triggered by emotional shock, physical stressors such as stroke, difficulty breathing such as an asthma attack, etc., can mimic same symptoms as Takotsubo cardiomyopathy. So basically, while this phenomenon starts with one person dying, it eventually causes the death of the second person. And we see this commonly when spouses, they've been married for 60 years or so, one dies, and inevitably the second person, the other spouse, falls ill and dies within hours or days of the first one. And this is inevitably in the condition or falls on the umbrella of broken heart syndrome. So broken heart syndrome is temporary heart condition that's often brought on by stressful situations, as I mentioned above. It can be triggered by illness or surgery. Patients with broken heart syndrome have sudden chest pain or think they're having a heart attack. There's a temporary disruption of normal heart's pumping function, and patients become cardiomyopathic. They have a very weak heart, and that actually leads to low blood pressure, arrhythmias, all of the above. It may be caused by a surge of stress hormones, as mentioned above, and the heart basically takes the shape of a Takotsubo or the octopus cup, the Japanese octopus cup. And chest pain, shortness of breath are common symptoms of these people having heart attack-like symptoms and heart failure. So exact causes are unclear. Again, stress hormones such as adrenaline might temporarily damage the heart of some people. And 80% of the people having Takotsubo cardiomyopathy are women. So when we look at the normal heart, it's ellipsoid shape. It basically pumps blood from the left ventricle out into the aorta and the body. With the Takotsubo and broken heart syndrome, the heart and muscle is enlarged, especially the apex, and the heart itself doesn't pump efficiently. Only the basilar portions of the heart are pumping. The entire mid and apical wall are basically bulging outwards. This is why patients become hypotensive and very unstable. And if you look at the heart shape in Takotsubo, it looks like the octopus cup that Japanese use to trap octopus. So again, this is with stress. You have stress hormones released, coronary spasm and arrhythmias eventually lead to stress cardiomyopathy. Again, the sympathetic nervous system has a surge of hormones leading to this Takotsubo syndrome. This is again the shape of the Takotsubo. So frightening medical diagnosis, domestic abuse, losing a spouse, strong arguments, all of these and more can lead to the stress hormone rush leading to Takotsubo. So it's possible that some drugs may cause broken heart syndrome by causing a surge of stress hormones. Epinephrine, such as using the EpiPen, it's used to treat severe allergic reactions or severe asthmatic attack. That may lead to a Takotsubo. Cymbalta, medication given to treat neuropathy, etc., can also, or depression rather, can also lead to Takotsubo. FSCAI, another antidepressant, same. Levothyroxine, Synthroid, levothyroxine, those actually can increase patients' heart rate and contractility, and that itself can actually lead to Takotsubo-like effects to the heart. So unlike a traditional heart attack where you have a plaque rupture and a complete occlusion of the artery and with thrombus buildup, in Takotsubo, the patients do not have a plaque rupture. They may have coronary spasm that may lead to inadequate blood flow to the heart muscle and the stunning of the heart muscle. So when we do the angiogram on these Takotsubo patients, they actually have clean coronaries. They may have some residual spasm, but overall, there's not that much sign of plaque buildup or plaque rupture. Unlike in the patients with acute coronary syndrome or a heart attack, where there's an actual plaque rupture that propagates platelet activation and aggregation and actual thrombus buildup in the arteries, leading to an occlusion of the arteries and a heart attack. So there are some risk factors for Takotsubo. Female sex, 80% affect women, as I mentioned. And most of these people with Takotsubo are 50 years and older. History of neurologic conditions. People who have neurologic disorders such as a head injury or seizure disorder, epilepsy, have a greater risk of broken heart syndrome. Previous or current psychiatric disorder can also make it more likely that these patients may have broken heart syndrome. So in rare cases, broken heart syndrome is fatal, but luckily, most of the time, if we're able to get to the patient on time and have adequate cardiac support, they will get through the very stormy course and then they can make a full recovery. They may also, but however, there is a chance that this condition may recur. So these patients have to be on medications such as beta blockers to shield their heart muscle from barrage of stress hormones and prevent future catastrophe of the broken heart syndrome. So again, long-term treatment of beta blockers that shield the heart muscle from catecholamine surge to the heart, they actually are deemed to be helpful in preventing recurrences of Takotsubo on these patients. So history and physical is important to sort of understand when this started and what's going on. EKG to see if there's any ST elevations and EKG changes that may lead us to think there's either a heart attack going on or a process leading to inadequate blood flow to the heart muscle. Echocardiogram is also a must for us to assess any wall motion abnormalities of the heart, and also see what the heart function is. So blood tests such as troponin helps us understand whether there's any heart muscle damage, and a troponin leak usually is consistent with heart attack, heart muscle damage, whether this is from an inflammatory process such as myocarditis or an actual heart attack where you have an occluded artery and heart muscle damage releasing troponin enzymes. Chest X-ray to also understand, for us to understand whether patient is in heart failure, fluid retention, etc. Some situations, cardiac MR is helpful to see if there's an actual myocardial stunning and viable heart muscle or scarring of the heart muscle that is consistent with a weak heart muscle that a lot of times may not revive, may not come back. And of course, cardiac catheterization to for us to understand the anatomy of the heart, of the coronary arteries, to see if there's an actual plaque rupture, occluded artery, or coronary spasm. So no standard treatment for Takotsubo, but again, patients, the treatment is similar to treatment for a heart attack until the diagnosis is made clear. So somebody comes in with Takotsubo, we're still trying to assess. I would definitely consider blood thinners, heparinization, aspirin, statins, and the same sort of treatment that we would give in patients that are having heart attack. Beta blockers and to shield the heart muscle from the catecholamines. If they have a weakened heart muscle, ejection fraction less than 40%, ACE inhibitors are actually important. And dietary modifications, avoiding red meat, processed sugars, caffeine, polyunsaturated fats, fried foods. And moving forward, obviously, heart health is important. Not only watching the diet, also exercise 3 to 5 times per week, raising heart rate 85% of the maximum predicted heart rate, which is 220 minus H, for at least 20 minutes. So update on our patient, Ms. T, she remained on ECMO device in the ICU. She was actually flown to USC with a helicopter as she was deteriorating, but on the ECMO device, she was on it for 8 days, slowly weaned off of the pressors. She woke up, was extubated, came off of the ECMO device. Repeat echocardiogram showed complete recovery of her heart function, and she remained in the hospital for additional 3 weeks and was subsequently discharged home. She sees me in the office and she's actually doing great. So in conclusion, stressful situations, in particular breakups, death of loved ones, can trigger surcharge of catecholamines, also known as stress hormones. Heart muscle sustained stunning, especially towards the apex, leading to an octopus cup-shaped contractile dysfunction, Takotsubo syndrome. Prompt and ongoing cardiac support is life-saving. Most often, this condition is transient in patients, and namely 80% of these being women make a full recovery. So I'm gonna have 3 quiz questions. Question 1, broken heart syndrome can occur after A, severe emotional stress, B, death of a spouse, C, extreme happy occasion, D, job loss, E, all of the above. And the answer is E, all of the above. Question 2, what % of patients with broken heart syndrome are women? A, 10%, B, 50%, C, 100%, D, 80%, E, 2%. And the answer is D, 80%. Last but not least, which 4 drugs may cause broken heart syndrome? A, epinephrine, Cymbalta, Effexor, levothyroxine. B, Viagra, Prevacid, Lovaza, Effient. C, Plavix, vitamin D, Propecia, Cardizem. D, Toprol, Synacot, Apixaban, Coumadin. E, Flomax, Brilinta, Ozempic, Metformin. And the answer is A. With that, I conclude my presentation. Thank you very much.